talk number 4 is on point of care ultrasound. I'm going to specifically focus on cardiac ultrasound because that is the most common and most useful kind that we use in the CTICU. So just to start, this is a supplement to clinical exam, labs, imaging, and hemodynamics. And a lot of the time, you can't really figure out what's going on with just the numbers alone. Sometimes you need to physically see the heart to either rule in or rule out the diagnosis. And it's especially useful in the cardiac ICU world because dysfunctional hearts are the most common, right? So it's most likely to be useful here just because you see the most cardiac pathology here. And the 4 views that we're going to go over are parasternal long, parasternal short, apical, and subcostal. So as a general rule, the different structures are viewed in different views, and the goal is to have all the views agree on the same finding. And if they don't, you kind of have to think. We think like, are we measuring something wrong, or is our initial reason for ordering the exam wrong? So let's go to first. We'll go to parasternal long. It kind of looks like this. How we get this view is that we place the indicator next to the sternum on the left side, hence parasternal, point it towards the patient's right shoulder, and then choose different rib spaces and kind of pan back and forth until you get something that looks like the image below. And what this is it's cutting longitudinally through the left ventricle, and you're seeing the free wall of the right ventricle. This is the most useful view for LV. You can see the aortic root, aortic valve, left ventricle, the mitral valve, and the left atrium. And for the right ventricle, you're going to see the free wall, and it's also useful to see anterior pericardial effusions. So those are kind of the things that you're looking for in parasternal long. Next, we're going to move on to parasternal short. And in order to get parasternal short, once you have parasternal long, you're going to stay in the same spot, and you're going to turn the indicator towards the patient's left shoulder. And rather than being a longitudinal cut through the left ventricle, this is going to be a transverse view, through both the right and left ventricle. And the true parasternal long is at the level of the papillary muscle. So I labeled them in the figure for you. What this view is best at is to see the systolic function of the left side and the right side. You can also pan to the apex, and then also pan back towards the base of the heart. Sometimes you can see wall motion abnormalities here as well. So the two things that you're looking for here is right ventricular and left ventricular function, including wall motion abnormalities. You can also see sometimes pericardial effusions. All right, we're going to move on then to apical 4. So apical 4 it's the most useful view, and this one is found by putting the indicator or putting the probe below the nipple with the indicator pointed towards the patient's left. What I find is that depending on the orientation of the patient's heart, Sometimes this can be next to the sternum. Sometimes it can even be in the mid axillary line. So it just depends on the patient. So what this apical view should be a longitudinal cut through the left ventricle, right ventricle, including both of the atrioventricular valves. There's tons of information you can get from this view. So we'll just start with the left side. You can see the EF of the left ventricle, thickness of the wall. You can also use pulse wave Doppler to measure diastology here, because this is something important for this view. The ultrasound beam is lined up with the tricuspid and mitral valves. So you can do, from the left side of the heart, you can do diastology and also characterize MS or MR, and on the right side you can characterize TR. You can also see the size of the atria relative to the ventricles. You can also look at the intraatrial septum, looking for right to left or left to right shunts. And then, so if you could choose one view to keep, it would be this view. There are supplementary views, and there are some for parasternal long and for parasternal short. I didn't include them because I don't think that they're useful for like beginner level, and I don't think that they add much. I don't think that they add enough information to warrant adding them to this talk. For apical though, there are two extra views that I do think are important to know, and the first one is the apical 5 chamber, and you get that view by moving the tail of the probe down. So you're gonna look up with the probe, and the 5th chamber is the left ventricular outflow tract. This is useful because the LVOT lines up with the ultrasound beam, and you can measure a VTI of the left of the LVOT, and you can also see if the aortic valve opens, and this is especially useful for the LVAD patients. The other useful view is the apical 2 chamber, and so to get this one, you keep the probe in the same place, rotate it 90 degrees so the indicator is pointed up, and this is just a longitudinal view through the left ventricle, and you just see different walls. So you see the anterior and the inferior wall, and so it just helps with wall motion abnormalities and systolic function. So all in all, apical is going to be where I'd say 75% of your information comes from. So the last view is called subcostal, and that one is found by placing the indicator, by placing the probe below the xiphoid process, and by indicator to the patient's left, and then look up into the chest in the patient's heart. So this is useful because this is often easy to get in code situations. It's plus or minus useful for the CTICU, just because patients usually have bandages and chest tubes in the way, but generally, if it's difficult to get parasternal views, the patient tends to have a good subcostal views. A subcostal view is good to look at the right side of the heart, because the right side appears falsely enlarged compared to the left. So this is good because you can see the systolic function a little bit better, but it's bad because the RV can look enlarged when it's really not. So just a word of warning here. You can also see inferior pericardial effusions from this view. One, I think, of the most useful views can be derived from the subcostal view, and that is, and you do that by focusing on the right atrium, turning the probe 90 degrees so the indicator is pointed up, and then looking at the IVC. So the IVC diameter and whether it's collapsible or not can tell you what the patient's volume status. And again, I'm not going to go into the details of that. Just know that this is how you look at the IVC. And the other thing is that you can use pulse wave Doppler on the hepatic vein to look for systolic flow reversal, and that's a sign of a severe TR. So overall, a subcostal, great view for codes. You can see the IVC, and you can see the right side of the heart really well.